Well, thank you very much, Professor David Vo. And thank you also for the invitation to speak in this forum. So I'll try and make it interesting. I'm speaking on the discovery of Avastin and the reduction in blindness in Australia. So this is a really very good news story. It's really the outcome of our talk is really summarised in this slide here, which shows us that blindness is falling in Australia. Our favourite disease I'll be talking a lot about today is age-related macular degeneration, AMD. So in the left panel, you can see the rates are really increasing a lot, and they're falling along with the other diseases as well. And on the right side that you can see, it was increasing at 2.4% a year, and now decreasing. We have a decrease in causes of blindness due to AMD, and it's all due to the development of Avastin. Then you think 2.3%, why do you worry about that? Because it's really expensive. So in 2004, vision disorders cost 9.85 billion, and that would otherwise be increasing. So I'm going to run you through a primer on retinal vascular diseases. Then I'll talk about vascular endothelial growth factor, which is our key molecule. Then the development of anti-vascular endothelial growth factor treatments. But simultaneously, there were other developments that we have to talk about. So there was a development of the OCT scanner, new methods of drug delivery to the eye, and then all of those strands come together, and I'll show you the outcomes that we've achieved before I mention the future directions. So, retinal vascular diseases. We're focusing here on macular degeneration. Up until now, this was a leading cause of blindness in people over 50. And diabetic retinopathy was the leading cause of blindness in people under 50 who were working. It's even more significant. So these are our key diseases. Now, looking at the eye there, we're all familiar with that, and you'll recall that the retina, the site of these diseases, is sitting at the back of the eye, much like camera film, and much like all the other parts of the body, the retina has blood running in through a little artery and back out again through a little vein. So there are pre-existing blood vessels. Now, the retina, small that it is incredibly detailed. So you can see 10 layers there, and we're trying to look at individual diseases within these layers. So if we look first at macular degeneration, which AMD, so the clinical model is that this is a disease which starts with small drusen, and there's some of the factors leading to the formation of the drusen waste deposits are listed there. But as time passes, the drusen start small, then they get big, then you get change in the retinal pigment epithelium, and then the whole lot just wastes away.
So what's drusen? How did it get its name?
I don't know. It might well be Latin for something like spot.
Oh, okay. So it's just some sort of junk or something.
Yeah. Metabolic waste debris. They're summarising, 100 papers there. Now, so you end up with absent tissue, geographic atrophy, and that's called dry macular degeneration. So the white patch there, the retina's gone. Now, at any step along the way of this clinical course, it can be early, can be late, most commonly in the middle, you can get new blood vessels emerging, and that's called choroidal neovascularization, and we call that wet AMD in contrast to the atrophic dry AMD. So in the picture there shows you the blood vessels coming out of the underlying normal choroid and breaking through into the retina. So there's two forms. There's the dry form, by far the most common, 80 to 90%, and the wet form as a minority, 10 to 20%, but they're the ones that lose vision. So 90% of vision loss in macular degeneration is from the neovascular or wet AMD. Now, it's not just the retina as a general area that's affected, it's actually the macula and even small subspecialized area, the fovea. That's the subject of this disease, and that's unfortunate because the fovea is very highly specialized to give you your best central vision. So the cone photoreceptors there are really highly specialized and give you the sharp acuity and the color vision. And this is an example of what happens when those cones aren't working properly. So the difficulty with visual tasks, reading, telling the time, recognizing faces, driving. So it's very difficult to work when you've got this type of thing all the time. Now, here's one of my old slides I made in 2004, and it shows you that neovascular AMD really increases rapidly up to age. So it's starting at age 50, and that the heading there, it says neovascular AMD is the leading cause of severe vision loss in people greater than 50 years. Now, that used to be the truth when I made this slide, but no longer, and that's what we're talking about. Now, we do know some risk factors, particularly family history and genetic factors, and we also know smoking actually increases the risk of neovascularization about 20 times. And now this is a model of development of AMD. So there are other models actually, depending on which of the various elements you think is your favorite pathogenic element. So I'm not going to go through it. It illustrates each multifactorial, many molecules, very complex, but I've circled VEGF-A, which is a molecule that we're talking about today. And I just wanted to show you, hitherto, verteporphyrin was the state of the art, and I'll show you some pictures of it, the results of that. Verteporphyrin, the state of the art, 2 stages. You had to give an intravenous infusion of a photosensitizing dye and then a non-thermal laser application onto the abnormal blood vessels.
So verteporphyrin is a dye that gets hot or does something when you shine a light on it.
Yeah, exactly. And it's supposed to preferentially absorb into the abnormal vessels within macular degeneration. Now, in diabetes, okay, now we're turning to diabetes. Previously leading cause of blindness, people under 50, and complex disease, microvascular, macrovascular, but microvascular complications are the ones we're thinking about here, specifically the retina. Now, the clinical picture here, it starts with just blister-like microaneurysms forming off the normal blood vessels. So they're highlighted there in the photo, but also in the angiogram. So in the angiogram, the eye angiograms, we inject coloured dye and then make it fluoresce and take photos of the dye passing through the vessels. Here's a little picture showing you the microaneurysm schematically coming off the retinal capillaries. So that's the start. That's not vision threatening, but if you let it go, then you end up with proliferative diabetic retinopathy, where here are some illustrative pictures of various forms of abnormal blood vessels branching off the normal blood vessels, but the new vessels come and they form scarring, bleeding. And in the bottom right panel, you can't see anything. The whole globe is full of blood, very visually devastating. In diabetes, you can also lose vision through diabetic maculopathy. So in contrast to getting abnormal blood vessels cropping up like weeds, the normal blood vessels can start leaking as well, and they can leak out serum, and they can leak out lipids. So here are some pictures of a lesser and greater extent of lipid deposition within the macula. Now, much the same as with age-related macular degeneration, there are many schema of how you end up with diabetic retinopathy. And again, in this one, again, I've highlighted VEGF-A is one of the contributing elements. Hitherto, laser photocoagulation was the state of the art. So you can see on the top right, the laser bouncing off a mirror and passing through the clear ocular structures. And the first time the laser hits a pigmented structure, it gives a thermal reaction. So we do that. Now you can see on the bottom pan-retinal laser photocoagulation. So all the white dots are the recently applied laser and the black dots are the previously applied laser with the scarring. So we use the laser to treat the new vessels in the periphery. And also we used to use it, a so-called macular grid laser, for the macular edema. But that is completely superseded now. So if I was to do a treatment like on the right there now, I'd be struck off, unethical practice. So it really shows you how things have moved on. But we still will use the peripheral laser. So this was the old state of the art.
So Heather, do you have a whole lot of old lasers sitting in your garage?
Yes, especially the laser that I think it was 810 or something nanometers. It was for the photodynamic laser, and we just never use it anymore. So yes. Now here, so I've just shown you our key diseases. Now we're talking about the key molecule, which I showed you was implicated in both of them, a vascular endothelial growth factor. And this picture here is trying to show you that usually they associate together, like people two together. So the story starts in 1948 when Michelson postulated a retinal angiogenic factor released by ischemic retina. So translation of that means when the retina has a poor blood supply and low oxygen through the retinal tissues, in response to that, the retina generates an angiogenic factor, which makes changes to the retinal vasculature. And it wasn't known what it was. And by the time it's the 80s, it was called factor X. And I actually, there's me as a medical student in the 80s and an ophthalmology trainee writing essays on this mythical factor X. So we fast forward 41 years and it was finally factor X was identified in vitro. So the sketch there shows you a capillary. So the light pink are the endothelial cells, which are like the inner coating of a tube around a red cell there. What we're seeing here is that the capillary is made of an inner layer of endothelial cells and an outer supporting layer of pericytes in yellow. These people in vitro identified a molecule that they found promoted the proliferation of the inner endothelial cells, and they proposed the name vascular endothelial growth factor instead of factor X. Now, the next thing that happened was we found that this VEGF that's found in vitro actually works in the primate model of ocular neovascularization. So in this image here on the top left, they induced ischemia, primate model, by lasering the blood vessels. And you can see in the control on top right, they lasered the retina, not the vessels. So they ablated the blood supply. And then down in the bottom, you can see then thereafter, the iris new blood vessels grew really red there versus the control, an orange iris. So there was a laser induction of ischemia. They found VEGF levels increased in the aqueous humor. The VEGF mRNA was upregulated. The iris neovascularization developed, and it was all temporally and spatially correlated. So it's looking good. We found factor X. And then it was associated with human retinal disease. So some really kind people with retinal vascular disease volunteered to have a vitreous aspirate. So you can see the needle there into the vitreous humor. So they just said, yes, fine, do take some fluid out of my eye. That'll be okay. And you can see in the bar chart there, the people with a retinal vascular disease had high levels of VEGF and the controls didn't. So that's looking good. And then in the final picture on the right shows you a dose response curve. So there's a final VEGF concentration applied to human retinal endothelial cells, and the DNA concentration there was used as a proxy for endothelial cell proliferation. And you've got a dose response curve there. So the higher the final VEGF concentration, the more the growth of the human retinal capillaries. So that was looking good.
Hmm.
So VEGF, okay, it's a protein, homodimeric glycoprotein, and it's not that simple. There's a family of them. So there's VEGF A, B, C, D, and E, and also placental growth factors in this family. But VEGF A is the most abundant form in the eye. And it's still not that simple, because even though you've just got VEGF-A, there's alternate splicing. So there's at least 9 VEGF-A isoforms, and they're numbered according to how long they are. Now, here's some of them. And the points here are that they all have a VEGF receptor binding domain, but only some of them have a heparin binding domain. Now, the big ones, the long ones, are thought to be more or less stuck in the tissues with limited mobility, and it's the smaller forms are more diffusible and thought to be more pathological. So these smaller ones are thought to be the key ones, especially VEGF-A165. And now the story gets even more complicated because the receptors are variable. So there's 3 receptors. So you can see here we've got VEGF receptor 1, 2, and 3, and the various members of the VEGF family interacting variably with them. But I repeat, VEGF-A is thought to be the most important in the eye, and VEGF receptor 2 is thought to be the most important. And for scientists, these are tyrosine kinase receptors. Now, for us ophthalmologists, the key is that VEGF-A is the primary driver of angiogenesis, and it mediates all the events that led to development of new blood vessels, so branching off the old blood vessels that are already there. So you can see in this picture how the endothelial cells are activated, the basement membrane is degraded, the cells start proliferating, and then they form little tubes. And then the maturation phase there, where the pericytes, the outer layer, gets applied to them. And VEGF directs all of that. Now, we're talking a lot about angiogenesis. Now, it's not all bad. Angiogenesis is obviously a physiological process, and it's a formation of new blood vessels via sprouting from existing vessels, like I just showed in the image there. And it has physiological functions such as reproductive functions and wound healing. But it can be pathological, of course. And so VEGF is associated with tumours and, as I've been showing you, ocular neovascular disorders. So, of course, it all turns out to be a balance. So in the physiological status, the positive and negative regulators are in balance with each other, and not so in the pathological states. So VEGF is highlighted there, but it's also interesting to see some other targets that might be helpful in the eye and other clinical situations. Right, so that's a sketch about VEGF and its receptors. Now, the next thing that happens is we have to find VEGF neutralizing treatment. Now, this picture here is a sketch showing you that the vast majority of the treatments here use antibody-antigen reaction, where the antigen is vascular endothelial growth factor, and you complex that with an antibody and you remove it from the clinical situation. So we're back to this picture. I did show you once already, but I left off one of the other information that it shows you. In each of these 3 pairs there, they're actually pairs. And in the second one, anti-VEGF was added to the VEGF that was in this in vitro experiments. And you can see that in each of the 3 examples there, addition of VEGF, anti-VEGF, slowed down the development of the retinal capillaries. So that was an in vitro demonstration that anti-VEGF might be a good idea. So now we fast forward to 2005 with the development of bevacizumab. So I'm sure Professor Gabo understands this diagram on the right much better than me, but what they started with human VEGF. So, okay, fine. So you inject that into mice you find murine, anti-human VEGF, and then through elegant manipulations, turn it into a humanized version. So bevacizumab Avastin is a humanized anti-VEGF monoclonal antibody, and you can see there it's 149 kilodaltons, a very big molecule. It was only for cancer therapy at this point, and it binds all forms of VEGF-A and therefore stops it interacting with the receptors within the family that it's going to react with. Now, at this point, at a critical juncture, Genentech was a company which had developed bevacizumab, and they decided it was too big to enter the retina. Now, that's because it's a large molecule, 149 kilodaltons, and there's a so-called blood-retinal barrier. So they could have bevacizumab in the blood vessels in the retina. You could get it there, but it wouldn't go out into the actual retinal layers. Then, because of a so-called blood-retinal barrier there, which I've illustrated in red, it's basically tight junctions in the blood vessels and within the retinal pigment epithelium. So at this critical juncture, development of bevacizumab for ophthalmology was halted, but it went ahead for cancer. So, but the anti-VEGF story continued with two new molecules and two alternate methods. So in 2004, pegaptinib was licensed by the FDA for treatment of macular degeneration. And in 2006, ranibizumab similarly licensed for macular degeneration. So different approaches entirely. So pegaptinib is an aptamer, which I wrote the definition there for myself, single-stranded oligonucleotide that folds into defined architecture and binds to targets such as proteins, and in this case, VEGF-165. An entirely different method was ranibizumab. So back to Genentech, further elegant modification of the murine antibody, and the ranibizumab you can see there is the antigen binding part of the bevacizumab. It's just a small section of the bevacizumab molecule, and so it's much smaller, only 48 kilodaltons. So two different approaches. If we look at the isoforms, the ranibizumab binds with the receptor and all forms of VEGF-A. Pegaptinib, unfortunately, bound to the heparin binding site and only some of the forms, and only VEGF-A165 was targeted at, but it didn't inhibit the other forms, and so actually it turned out to be not clinically useful. So a huge development program against VEGF-A165 had to just go into the cupboard. And that left us with our hero molecule, which is ranibizumab, a fully humanized antigen binding portion of the anti-VEGF-A monoclonal antibody. It binds and inactivates multiple isoforms of VEGF-A, not just 165. It's shown to decrease vascular permeability, inhibit endothelial cell proliferation and migration. It can penetrate all retinal layers and inhibits the formation of new vessels. So all of the actions of VEGF that I showed you on the slide inhibits all of them. Yes, but the ophthalmologists didn't listen to Genentech and proceeded, so hence bevacizumab redux, off-label. Now, the label means as approved for use for a specific indication for bevacizumab, that's cancer. So the label for bevacizumab at that point says cancer, but they used it off-label, so for a different indication. Now, that doesn't mean it doesn't work, and it also doesn't mean it's unethical. It's just off-label, and the patients have to understand that well when they consent to treatment. So the heroes in Florida gave some intravenous bevacizumab and found their patients improve their vision. And the picture there shows you on the top right, it shows you the white leaking of dye from a blood vessel pre-treatment, and down in the bottom right, it shows you the leaking's been abolished by the intravenous bevacizumab, which must have therefore entered the retina, even though it was supposed to be too big. There was a case report in 2005 where a male with central retinal vein occlusion was given with very good informed consent, intravitreal, IVT, it means intravitreal, bevacizumab, and this picture shows you its improvement in vision from 660 to 618. So this was bubbling along. So we end up with our hero molecules. These are our clinically available variations of anti-VEGF agents. So we've got bevacizumab, though that's off-label, the full-length humanized antibody. Then we've got ranibizumab, which is just the antigen binding section of the bevacizumab molecule. Then we have aflibercept, slightly different. This is a fully synthetic fusion protein. It does have the so-called FC section down the bottom, but those blue semicircles are actually VEGF receptors 1 and 2, which have been synthesized into this molecule, which is previously called VEGF trap. So the VEGF was supposed to bind onto the receptors and trap it. And then lastly, and most recently, brolucizumab was only been released in the past, say, 1 to 2 years, and that's even smaller than ranibizumab. So it's only a short chain variable fragment, and you're right down to 26 kilodaltons. The unifying features of all of these 4 molecules, that they're all really based largely on antibody-antigen reaction with VEGF as the antigen. They all inhibit all forms of VEGF-A, and this all happens in the extracellular space so that the drugs grab onto the VEGF and remove it from the extracellular space, and therefore reduce binding to and activation of the VEGF receptor. Right, so we have our drugs. Now, the next thing that happens is development of optical coherence tomography scanning. So this picture here is showing you, this is scanning, which is real time imaging of the retina done by technicians. And the reference there is a very good summary reference. The development of OCT scanning was a major scientific advance, and it took worldwide cooperation, but key players were scientists at the Massachusetts Institute of Technology and retinal doctors at the Harvard Medical School at the Mass Infirmary, because they're so close, you know, they're just over the bridge from each other, and they could collaborate quite closely. This was our starting point back in the 90s. So we're trying to work out where the blood vessels are growing and which retinal layer is disrupted, but this is a technology we had to do that. So there's Fred Hollows with a torch. We've got our photos, our angiograms, and we could do ultrasounds, and we could do CT scanning, and that's about the resolution of scanning back in the day. So clearly we needed an advance, and we got it. So in 1991, the OCT, so optical coherence tomography, this was the first publication about it. So it's based on Michelson interferometry, which other people will understand more than me, but you end up using a beam splitter and looking at how a bit like ultrasound, how the tissue reflects back to the sensor, and the comparison between the moving mirror depth. So the pictures on the right are from the original publication. So that's one single slice, or A scan as they call it, showing you the optic disc and the retina. And you can see it's the scale there is labeled log reflection, because you're doing reflections of light off the various retinal tissues. And the panel B there is the autopsy eye that they were scanning. So that was remarkable. The first clinical prototype there based on a slit lamp came in 1993. Back in the 2000s, we had this type of image and we could start differentiating the various layers almost to histological clarity. And now in 2022, this is what it looks like. So it's called swept source OCT now. And you can see in exquisite detail all the retinal layers. And you can also do so-called OCT angiography, where the vessels are defined by the movement of blood vessels, of red cells through them. So this is remarkable. It uses a laser light source. The A scan in the first picture I showed you in 1991, we're able to now achieve 100,000 of those per second. And the acquisition time for that, the line scan there, as we'll call it, is less than 1 second. And we get resolution 10 microns or less. It's truly remarkable. The angiography takes a bit longer, but that's really rapidly developing as well. And the panel there on the right shows you just how much resolution we're getting. The OCT in blue is actually better resolution than MRI scans and ultrasound. So it's pretty remarkable, but also very good to assist us. Now, the next thing that happened, we needed to develop novel methods of drug delivery to the retina, because it turns out to be actually quite difficult to get drugs to the retina. So if you look at that panel on the right side in the green, it says static barriers. So that means if you say apply an eye drop, it's got to work its way all through these various tissues, the cornea, the iris, the lens, the vitreous, right down to the retina. And down on the bottom right there in orange, there's the blood-retina barrier and blood-aqueous barrier that I was talking about. So even though the molecules might be in the blood vessels, they can't escape into the retina. And then on top of that, if you put something in the tear film, you just blink and it vanishes. And on top of that, if you get the drug into the retina, there are actually pumps, little enzyme pumps that'll pump them back out again. So it is really hard. So if for a topical treatment, for example, if you thought I'm going to put on an eye drop and get it to the retina, you need to think again, because it will, much of it will actually not even reach it to the surface of the cornea, because it will run down the nasolacrimal channel by blinking. And if it gets deeper in the eye, it's actually actively cleared. And then finally, less than 5% of the applied drug might reach the retina. Then you might think, okay, let's do intravenous therapy, which is actually has been done and was a state of the art when I was a trainee. But the total retinal blood flow is 46 microliters per minute, which is only 0.01% of the body blood flow. And then if you actually get some drugs into the retinal vessels, then they have to penetrate the blood-retinal barrier to actually reach into the retinal structure. So you can do that. And actually the study that I showed you, off-label bevacizumab, you can do that, but you get to the point where the systemic toxicities are outweighing the therapeutic effects. So this was more or less invented, intravitreal drug delivery. So you can see the picture there of a patient lying down in the clinic and their eyes held open by a speculum paperclip type arrangement, and that's a 1 ml syringe in the ophthalmologist's hand, injecting the drug into the vitreous humor. There it is. So of course, we're bypassing all the anterior barriers and reducing the risk of systemic toxicity, but there are significant complications, infection, retinal detachment, and especially when you consider repeated treatments are necessary. And for example, there are people in Melbourne, they've had 100, 200, 250 treatments as time goes by. So the complication risk increases. So now, back in the day, retinal specialists might administer 1 or 2 intravitreal injections per year for infections in the eye. That was it. The first anti-VEGF agent injected into the human eye was pegaptinib Macugen, given in 1999. 2000, the retinal specialists were really not keen on that. And a global survey showed 90% thought that intravitreal therapy is not appropriate for routine use. And fast forward 16 years, and worldwide estimate for 2016, 20 million injections. And it continues to escalate logarithmically. And I, for example, give about 80 per month. Now, so we have a new method of treatment, which is now widely accepted. Okay, so we put them together. We have a new drug. We have a scanner to show us what we're doing, what we're achieving, and we have a new method of delivery. So does it work? Yes, it works. So here we have the two studies that transformed treatment of macular degeneration. Now, you don't need to look at them. You just need to know that there were sham arm and a Vision-Eye arm, and that was the state of the art. So all of these charts I'm going to show you have running up the vertical axis increase in letters read. Now, that's a relative value. It's not absolute. So, and they're from each DRS chart, as it's called. So that's shown there. So a person that can read 80 letters reads the whole chart. A person that can read 5 letters is only reading the top line. A person that's increased 5 letters, you don't know at what point the 5 came from. Now, this graph here is showing you Marina down the bottom. Marina sham is showing you the natural history of wet macular degeneration, so devastating visual loss over 2 years. The green line is showing you the previous state of the art. This was the treatment, Vision-Eye verteporphyrin, and it really just slowed down the natural history, but this was the treatment. So the community sees this, and it's remarkable. So we see people improving their vision, and remarkably. And that's age-related macular degeneration. Now, with diabetic macular edema, the same thing. Different doses of ranibizumab, spectacular, laser state of the art, not much difference. You can also give anti-VEGF injections, ranibizumab, for diabetic retinal new vessels. So instead of stopping them leaking, you want to shrivel away the new blood vessels that actually come, and anti-VEGF can do that. And here it is. Here's the preliminary data showing that the visual acuity is better with ranibizumab versus PRP, right up until you look at the 104 weeks where the error bars overlap each other. So it looks kind of promising, but that's not quite enough to adopt for routine care, and that's why they're crossed with PBS. So the PBS does not fund this, but it funds the other treatments.
Well, in that graph there, was the treatment only given at the start, or was the treatment given throughout the 104 weeks?
Given every 4 weeks throughout the 104 weeks. So there was that. And lastly, another common disease, retinal vein occlusion, different types of it there. This one, you've got different doses of ranibizumab versus no treatment. And then the dotted line there shows the people that were in the control arm were switched over to the treatment. And you can see that the ranibizumab works really well to improve vision in both of these conditions. And that if you delay treatment by 6 months and then try starting treatment, it's not as effective. So it really a very good idea to start treatment as soon as possible. Now, I put in some cases to show you. This is back from 2013, some of my patients. Here's a patient with early AMD presenting with visual acuity just off 6/7.6. And you can see the abnormal blood vessel as the white blob on the OCT scan beneath with the left eye normal. And we treat this patient with lots of ranibizumab with modest effect. You can see the retina so-called drying out, restoring normal anatomy. And with ranibizumab, that looked good. I mean, the patient could see 20/20, 6/6, but aflibercept came along, so she switched to that, and we achieved this. So the patient returns to 6/4.8 vision, and this is maintained over about 18 months there. So very impressive treatment. And here it is, the late results. So really very impressive restoration of normal anatomy. Now, it also works in some people with advanced AMD. So here's another patient who came in less than 660, both eyes, very highly disorganized macula, legally blind. This man's legally blind, and hitherto it's like, okay, nursing home for you, along with a blind pension. I treated him back in the day with what we had, and the right eye there, you can see improving slowly over an 18-month period. So at the end of 18 months, we've got him back to 6/7.6. So he's had a spectacular improvement in vision. And so he can live his life, he can drive, he can use a computer, everything with this treatment. And it's spectacular, and that's why the treatment is funded. Now, we're just going to have a look at the long-term outcomes in some large data sets. So in the UK, so each of these images, the good vision is at the top, bad vision at the bottom. And you can see that the rise in vision, that we're all very excited. And then you can see it gets to 2 years and the vision goes back to baseline. The effect wears off. Very large data set. In Australia, on the right panel, we have a smaller data set, but in Australia, the luxury of treating far more aggressively than in the NHS. So in an Australian 7-year data set based in Sydney, the corrected vision only overlaps with the uncorrected after 7 years. So,
and I note that on the right, the scale is months, whereas on the left, it's just weeks. So
yeah,
that's much, 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 much longer.
Yeah, exactly. So 3 years on the left, 7 years on the right. So, and the red line on the bottom panel shows you the natural history. But I haven't got the data here, but in Australia, we treat very aggressively and much more frequently than in the UK, but we get better results. Now here's another piece of very helpful information from that UK data set. So instead of lumping everyone together, they're stratified. For the first time, we're seeing absolute vision, not relative changes. So they're stratified by the people in the bottom and the purple start with a low vision, and the people on the top in the red start with the best vision. So you can see there that the purple people, they get a pretty impressive gain, but it's from a low base. So they've still got low vision at the end. So they've got the best gains, but it's still low. But on the red people who start with the best vision, you can see the decay in outcome that we see in all treated people, but they've still got the best vision overall. So we use also this information to tell us, get started early. We think there's a new vessel. We really want start our people when they're on the red line and not on the purple line. Start treating when they've got best visual acuity. It's your best chance of having a good long-term outcome. And we have really taken this message to heart. So here is a chart of the government cost of PBS biologic drugs. Recent data, 2020-21, the number one biologic drug paid for by the Australian government is aflibercept. Many prescriptions and $425 million just for the drug. And then ranibizumab ranks 7 and another $210 million. So 4.6% of the expenditure of PBS on biologic drugs is actually on anti-VEGF drugs for retinal vascular disease. Now we think, which one is better? Well, it depends on the disease. Now, these are hard to interpret, but these, I'm showing you some forest plots. So you have a vertical line there, and you see down on the bottom favors ranibizumab, favors bevacizumab. So the diamond shape there shows you the group together results in a meta-analysis, and it's crossing the 0, or it's crossing the 1 line there. So it doesn't favor either. So macular degeneration, they're probably equivalent. And another way of looking at it is say, okay, we've people quote fail ranibizumab quote, okay, let's switch them to aflibercept and see what happens. And again, the down on the bottom crosses the 0 line, they're equivalent. And diabetic macular edema is a different disease, and aflibercept might be better. So they're circled, I've circled there the plots where aflibercept, diamond, clearly free from the 0 line. So aflibercept is suggested to be better than bevacizumab, and similarly aflibercept better than ranibizumab. And the Sydney guys, the Safe Side registries have another way of looking at this data there, where they're looking at predictions versus actual. And what they find is that summarizing, the vision at the end is the same with ranibizumab or aflibercept. However, the retinal drying is quicker using aflibercept. So even though the end result might be the same, it's quicker to get to the end result using aflibercept. And basically the same thing in retinal vein occlusion. So again, the Sydney data set. So end result of vision, the same, speed to get there quicker using aflibercept. So there are some impressive data on our drugs. So what happened to blindness? Well, here's data from the Lancet Global Health, showing you age standardized prevalence of blindness, comparing 1990 and 2020 in the old people. And I just put the panel of age-related macular degeneration here, skip the other diseases, and you can see it's falling in nearly all of them, except southern sub-Saharan Africa. Now, it's difficult to imagine that some of these countries here, such as tropical Latin America, are spending vast amounts of money on anti-VEGF drugs. So there's probably some other factors as well. But age-related macular degeneration is globally decreasing, which is very impressive. And it is back to the start, and it's decreasing in Australia as well. And now,
so Heather, what's the cause of the increase up until 2006? Is that just an aging population, or is there something else?
Well, you might imagine there's something else, because I put the picture there of the verteporphyrin injection there. And you know, it's pretty impressive how much the blindness rates increased while we were using state-of-the-art treatment. So hard to say. So, but anyway, so back to the recent Australian data, it's now decreasing steadily, which is fantastic. And the government's very happy with the reduced expenditure. Now, diabetic retinopathy, this is a bit older data and a bit harder to see, but if you look at diabetic retinopathy, on the bottom left, the dark is 1999 and the lighter bar is 10 years later. And you can see the fall in diabetic retinopathy blindness in the UK. And you can also see, and therefore, now that diabetic retinopathy is a lower percentage of the total of blindness, hereditary retinal disorders are now a higher percentage. So that's diseases like retinitis pigmentosa, which I'm working on. They are now the leading cause of blindness in people of working age, and hence the tremendous emphasis on treatments such as gene therapy. So this is pretty spectacular. diabetic blindness has reduced due to effective treatment. Now, some future directions. Okay. New drug targets combined with anti-VEGF-A. So anti-VEGF-A are excellent drugs, really fantastic drugs, but can you combine them? So there's a little capillary. Now, the first one that was tried was combining ranibizumab and platelet-derived growth factor antibodies. And that was a drug called Favista, which failed. And more recently, faricimab is one molecule which will bind both VEGF-A and Ang2. And that's actually just been approved by the FDA for treatment of age-related macular degeneration and diabetic macular edema. So we'll see how the real-world data shows up, but that looks to be promising. Now, Opthea. Opthea is a startup company in South Yarra, and you can see their drug there, OPT-302, actually targets VEGF-C, VEGF-D, so entirely new targets. You notice there that C and D do also act through the VEGF receptor number 2, which is thought to be the most important of the receptors. So there's definite possibility, particularly when used in conjunction with anti-VEGF-A. Okay, the next thing is, okay, we like giving our intravitreal injections, but it is a bit of a burden for the patients. And if we could have longer action, it would be better. Now, here's a refillable port. So you can see the patient has a port, a plastic port that stays there permanently implanted into their eye, and you just top it up. There's a refill needle. So you periodically top it up. So instead of having to have the complications of going directly into the vitreous, you go into the port instead. And this has been FDA approved. Even more out there is gene therapy. So here we have adenovirus vector, and the protein product that comes out of the end of this is aflibercept. So this gene therapy is injected into the vitreous, and we're very good at intravitreal therapy delivery. So delivered into the vitreous and continuously supply aflibercept to the retina. So I think that's still in clinical trials, but it's a very interesting idea. And then there are more variations on the same anti-VEGF-A drugs. The company called Kodiak has one, and there's another one there called abisapar pegol, which I don't really understand the molecular structure of. Something's called DARPin repeats attached to polyethylene glycol. The thing with these new ones is they're really very large molecules. And we all remember back when 149 kilodaltons bevacizumab was supposed to be too big to enter into the retina. So we wonder if there is actually a threshold, but we'll find out. So these are the directions that our excellent treatment is working towards to make it even better. Now, there are some Australian contributions. So there's Andrew Cuthbertson, formerly, I think, scientific director of CSL, and he was working at Genentech while they were developing bevacizumab and able to give them information about ocular structure. They were cancer doctors. They didn't know anything about the eyes, and he worked closely with them. Alex Sonia Jr. is in Sydney. Now, I have not talked about dosing regimes other than that we treat very aggressively in Australia, but this guy leads it, and he's developed this thing called Inject and Extend treatment regime, which is now used largely worldwide off-label. The label says give it every 4 weeks, but instead we use a different regime. And finally, Mark Gillies, who established the Fight Retinal Blindness Registry in Sydney. So we have a huge data set for Australia, but also all through Europe now. And we're getting excellent real-world data to show us our real-world outcomes versus clinical trials. So some really interesting Australian contributions. So thank you for listening to the VEGF story and the reduction in blindness that we've been able to achieve.
Oh, that was wonderful, Heather. So I'll ask people to put their questions into the chat box, and I'll also ask you to stop sharing your screen, Heather, so we can get a full view of you.
I don't know if that's good or bad.
All right, so let's see what's been said. Oh, they're just everybody's saying, what a wonderful talk. So is a question from Hamza Pathalikath. With a permanent port, how do you close your eyelid? So that's referring to that implanted port.
That's actually a very good question. The port is really very small, and the images, I've not seen one in real life. The images show it flush with the conjunctiva, but you're quite right. It might just feel like there's a foreign body there the whole time, every time you blink your eye.
Jimvo has said, made a comment. He's saying that Druze is the German for node, and drusen is the plural. So I guess it means like nodes or lumps, drusen.
I knew it was something like that.
And then there's just lots of fantastic talk, terrific talk, fantastic presentation, etc., etc., etc. Oh, here we are. With the port, how do you stop infections, etc.?
Well, very good question. And I just can't see this entering routine practice, partly because you have to keep topping it up. So if you're going to top it up with an injection, there's not that much difference between that and a routine intravitreal injection.
And a question, given the angiogenic causes, do mountain climbers, I guess at low oxygen pressure, and free divers suffer increased rates of disease?
I've not seen data, but that probably means that they don't. And that's probably because the retinal circulation auto-regulates. So
I remember Ian McKenzie, you know, the immunologist, pathologist, University of Melbourne at the Austin Institute. He said that he used to go diving a lot. And he said that if you look at somebody's retinas after diving, you often see leakiness. So that's something to keep in mind, I guess. Changes in pressure. And then there's a question, why did the Australian study have a 7-year benefit versus the UK 2 years benefit? Was the difference explained?
we think the difference is because we inject so much more aggressively in Australia. The studies, there was another one which I didn't put in, which showed that the average number of injections per year for Australians is about 7.5. And for UK, it's more like 2 to 3. So it's simple. And so it's thought that the UK people are undertreated.